Okay. Thank you very much. In this case, actually, this session has to be live in a box. However, the patient was apologized in the last minute. So it's going to be one of our cases we did recently about TAVR. So 78-year-old male, no case of diabetes type 2 hypertension, severe aortic stenosis, post-tissue valve replacement had one 13 years ago with a CE Magna valve size 21. He presented to our center with dyspnea NYHA class 3 to 4. And we did an echo for him, and his echo basically showed preserved LV function, severe aortic stenosis in the previous degenerative, basically surgical valve, with aortic valve area 0.81, aortic valve index 0.48, with DVI 0.19. As you can see here, we proceed with a cardiac CT for him, which showed basically parameter of around 19 with area of 284. And you can appreciate other values regarding SVOD diameters, STJ, and on the right side you can see the sinuses heighted for left coronary artery, right coronary artery, and the non-coronary cusp, basically in the acceptable range. No major concern regarding his basically iliofemoral axis on both sides. And as usual, we do in these cases valve to STG height and first to STG distance, the right coronary artery and left coronary artery. It was 5.10 and 6.5 millimeter. Now, in this patient, basically, in summary, he came with degenerative surgical valve and symptomatic at this stage. Basically, considering his age, the discussion was to proceed for basically TAVR in this case. So I'm going to come back to this, what we did in this regard for this patient, but I'm going to go briefly about basically review what should be done in case of TAVR. So generally, this is what the guidelines said about the classification of bioprosthetic valve dysfunction. Regarding the mechanism, we can basically classify the mechanism of dysfunction into four causes, usually causes related to structural valve deterioration or related to non-structural valve deterioration, which include basically patient or prosthesis-patient mismatch, or thrombosis and endocarditis. Now, when we talk about imaging, I think this has been really shown in the morning. So from a point of view regarding structural valve deterioration, according to the European Association of Percutaneous Cardiac Intervention, that could be classified into four stages. Stage 0, basically, when there is a normal valve morphology and function. Stage 1, when you have intrinsic function, but yet not to cause any basically functional abnormality. Stage 2, when we have both intrinsic and functional abnormality, but yet not to cause severe gradient in the mean transthoracic gradient, basically between 20 and 40. When the gradient more than 40, then basically this is classified as stage 3 or severe hemodynamic structural valve degeneration. Now, the echo also can tell basically if this is prosthesis patient mismatch or obstruction. It's mainly regarding two items. Now, if the valve itself looks normal in function and normal structure and motion, this is basically suggests PPM more than obstruction. While if the patient is abnormal valve structure and function, this will suggest obstruction more than PPM. Then if the increase in the mean gradient and decrease in EOE, which is effective orifice area, during follow-up is less than 10, this will suggest basically PPM more than obstruction. While in that more than 10, then basically would suggest obstruction as a cause of valve degeneration. Now, few consideration when you see patient and you refer him regarding which category he go for TAV and SAF or redo SAVR, regarding the patient himself, the anatomical variables and the surgical valve criteria, basically. So if we deal basically with high-risk patient, as usual, elderly patient has comorbidities, significant paravalvular leak that is not amenable to percutaneous closure, or patient preference, this has to be considered in the decision usually when you refer patient to TAV and SAF more than redo. While if the anatomical basically favor basically going for TAV and SAF, including high risk for coronary obstruction, high risk of malopposition or high risk for aortic injury, then probably TAV and SAF is preferred. If the favorable coronaryectomy and calcified aortic valve, then probably surgery is the option. Now, regarding the surgical valve itself, if that valve small size where severe PPM cannot be addressed, then basically surgical valve will be the option. The same with a large size without severe PPM, probably transcatheter is the option. Now, regarding the procedure planning, 4 items you have to remember. First of all, determination of the type and the size of the old valve. Determination of the type and the size of the new valve, which talk about TAVR here. Assess the risk of coronary obstruction, then predict the hemodynamics after valve and valve, and the need for post-deployment dilatation or bioprosthetic valve fracture. Now, we know it's very important to know the type and the size of the old valve, surgical valve, and the surgical valve could be divided into 2 types basically. Depends on the internal leaflet where it's basically mounted. So if the internal, if the leaflet, where is mounted, so if internally mounted, this is called stented valve, surgical valve, or externally mounted leaflet, then it's called stented valve. Then the stented valve itself could be divided, combined in the material sensitized from into bovine or basically porcine valve. This is very important to know in the history because that will tell us basically the internal diameter relationship. So when we talk about externally mounted, usually external mounted internal diameter equal to the nominal stent value here, as shown here in the true internal diameter. While we're dealing with internal mounted basically leaflets, then the internal diameter depends on the type. If this is basically porcine leaflet, this is going to be the true internal diameter 2 millimeter less than the nominal. And if we deal with bovine pericardial leaflet, then usually it's less than 1 millimeter as shown here. Also, the size or the type of the cervical aortic valve could be basically known from either going from the old surgical valve of the patient. Sometimes we do fluoroscopy to know the type of the surgical valve. Sometimes cardiac CT might help to know basically the type and the size of the old valve. Now, going to the next or the second item is very important to determine the type of the size of the new valve. And this is basically depends on the platform you're going to use, either it's self-expandable or balloon expandable. In generally, supraannular, the self-expandable valve demonstrate in some trials that it's superior in terms of hemodynamics outcome, especially when we talk about setting of small surgical aortic valve. And when we say small surgical valve, we mean basically the valve size less than or equal to 21 millimeter. This has been shown in basically a recently published trial looking for around 100 patients, basically randomized to go for either basically TAV and SAF with Edwards or TAV and SAF with self-expandable valve. At 1 year, basically no difference in clinical outcomes. However, when you look to the mean gradient and the peak gradient, it was basically more reduction when we talk about self-expandable valve versus balloon expandable valve. Now, another basically some factors could be also could make you choose one valve and another. When we talk about generally about smaller valve, as I said, it's favor self-expandable valve. When patient need coronary access in the future, or we're dealing with pure AI as a pathology in a stented surgical valve, or the balloon fracture is feasible in this patient, probably balloon expandable is preferred. If the patient sees a fracture of the valve is not feasible, so probably is not safe, then you go with self-expandable valve is better. Now, how to determine the new size of the valve? Basically, you could do that basically by cardiac estimation of the true internal diameter to tell you which the valve you're going to use. Or you can use the valve-in-valve application, which is basically was done by a group from Germany. All what you need some basically to put the type of the valve, then basically it's going to tell you whether the valve is fracturable or no, and what the true internal diameter size of this valve. So going to the third item, basically assess the risk of coronary obstruction. This is very important, whether this is acute or delayed coronary obstruction, and the risk is although low, but once it's happened, is very fatal. So there are different mechanisms why obstruction could happen during TAV and SAF or during TAV, generally even native arteries. We'll talk generally about direct obstruction by coronaries by leaflets, could be indirect, basically, obstruction, by sequestration, where leaflets block the entire sinus of a valva. Could happen also from calcified nodule of the leaflet itself. It could happen by TAVR commissural itself, either bust or skirt. Then obstruction could be by embolization, happen during the procedure by thrombus or degenerative material. Now, very important, as presented early morning, to calculate some basically diameters to assess the risk for an obstruction. That will help, but basically, first of all, looking for the extent or the leaflet extent above the coroneosteum. If this is actually the case, then no need for any procedures to protect the coronary arteries. If the leaflet extend above the STJ, then basically, if this is not the case, you calculate basically the valve to coronary distance. If this is less than 4 millimeter, with dealing with type 3, basically, or type 2B valve, then consider basically coronary obstruction. And the data basically not supporting any techniques in that regard. It depends on the patient operator experience, whether to go with the basically chimney technique or basilica technique. Then we'll go basically to the last important thing, which is basically predict the hemodynamics of the valve and valve. We do this routinely in all cases, and this is very important because 19% risk, increased risk mortality if the patient has severe prosthesis patient mismatch, as shown in multiple studies. The risk of also 44% in patients who has that have heart failure or rehospitalization within if they have basically residual gradients. Now, when we talk about structural valve degeneration, as a risk per se, it increased basically by 2.3 in those patients with residual gradient. Now, we could classify that basically based on index effective orifice area, which is divided basically effective orifice area by body surface area into mild, if that more than 0.85, moderate, if that between 0.85 and between 0.65, severe, if that less than 0.65 centimeter square by meter square. So what we do usually, we go to the patient's body surface area calculated and index, then we're looking basically where you basically predict that based on different chart from basically, you could do that from the companies and circle representative. There is online actually, there is online website where basically you could get the predicted basically hemodynamics for the patients in terms of effective area index. Based on all what you need to basically to have body surface area. Then you look for what's the new valve you're gonna insert or deploy in this valve, in this patient. So based on that, you get a number, and this number in green, basically it means you are good. Probably there is a low risk or mild risk of having a severe PPM with low effective orifice area index. Then this area in orange or yellow, basically moderate range, and red and severe. And this could be, basically depends on the new valve. So in this basically table, this basically for evolute valve, for self-expandable valve, and this one for self-expandable valve. So this is probably one last. Now there is basically another website. This is from Europe Medtronic.com. You go there and you enter basically the annular size, the body weight and height of the patient. Then you get the body surface area, and based on that, it's going to give you the effective orifice area index, and you basically tailor your procedure accordingly. Now, when you talk a few slides about في time ولا discussion time. So when you talk about bioprosthetic valve fracture in general, it depends on basically the response. Not every surgical valve responds basically similarly. And some surgical valves basically are not surgically or not fracturable by balloon. So talking in general, some valves basically will to be truly fractured, but depends on the site of fracture. Some of them they have basically in the swing, some are totally separations. So depending on the type of the surgical valve, the fracture might be visible or no, and the fracture itself might be different from valve to valve. Currently, we have two brand balloons that used for, basically, it's a non-compliant balloon. And in that regard, we have basically the True balloon and the Atlas Gold balloon. And each balloon can go to different, basically, or to some nominal or extra-nominal pressures. Now, to do that, basically, the recommendations to go inflating balloon, basically, the valvoplasty balloon is connected to other stepway cock with other, basically, syringe, usually 60 cc. Then, after you basically finish the inflation through the valvoplasty balloon, inject the extra air, basically, until you have the fracture or the balloon has rupture in these scenarios. So this is basically a pinch of basically mitral flow by prosthetic valve that was fractured, and the shape of where the fracture site in relation to basically balloon. So you could argue what could be basically advantages and disadvantages of having the fracture to be done before TAVI or after TAVI. Every approach has its own pros and cons. Basically, going with balloon before TAVI has the advantages of easier to implant self-expandable valve with less sizing mismatch, confirm successful fracture before finalizing TAVI size. The disadvantage is basically having acute severe eye causing hemodynamic collapse. This is why most operators, they usually avoiding having basically pre-TAVI or pre-TAVI-SAF balloon fracture, prosthetic valve fracture. Sometimes we need to post-dilate to optimize hemodynamic in those patients. Having the fracture done after TAVI-SAF, basically you have better TAV expansion, especially in balloon expandable valves, and less risk of acute severe eye. But talking about basically disadvantages, that TAVI-SAF might migrate or embolize. You might get acute TAV failure from leaflet injury and non-effect on durability because no data in this regard. So going to our patient, the patient basically in this regard has a parameter drive of 19 with area of 284 with a parameter of 59. Regarding the LVOT sizes, almost the same, no differences. Generous SVOT with around STJ also in the same range. Looking at axes in both and left, just look okay and acceptable, so we don't have really major concern regarding coronary obstruction or the need for protection. We went into the valve and valve application, considering the old valve CE Magna. Ease was around 3,300 by prosthesis. So these basically give us a true internal diameter of 19, and it is a fracturable valve. So we went to basically our chart. This patient is already in the moderate to severe range after potential our potential procedure. So we estimating we're going to have residual gradient, and we already prepare ourselves by having basically Atlas balloon to be ready in case most likely we're going to need it for balloon fracture to achieve hemodynamic. So we started the case by having an angiogram done, left and right, both normal, no coronary disease. We put sentinel then, and after that we started to deploy basically evolute size 23 valve, deployed as usual in commissural alignment and cusp overlap. Then we did post dilatation initially with crystal balloon size 18.
Based on the chart you show us, there was already a mismatch which is in the moderate range, and you are now really expecting there will be a significant gradient with the supraannular. So I'm gonna ask a question to Sundus before you proceed. Sundus, now Dr. Sundus Samargandi is like an amazing structural intervention. She loves structural, especially the right side of the heart and tricuspid valve and mitral valve. So Sundus, you know that now there will be a gradient, and this valve is fracturable. What do you think, to fracture it before and after?
Yes, it's working. So in my strategical, the way that Dr. Abdullah has mentioned it, I would rather to fracture post, because I will have an understanding, because once the valve has been deployed, the self-expandable one, I would like to do a hemodynamic as a prediction of what's going on. As I can see, there is 2 pigtails. After that, it will help me to consider fracturing or post-dilate, because from here I cannot see much of how much if the valve is expanded, but if it's under-expanded or, a bit of squeeze, I would go with post-dilatation or maybe fracture, as in this case.
Okay, so you know that, or we noticed that most of the small valve, either in a small lady or on a patient, a big guy with a small, big annulus, but it's bicuspid. So some of the surgeons, they bought small valve in this like big annulus. So some people, they advocate that if I fracture the valve, it allow me to put 26 rather than 23 evolute, for example. So what you're gonna make difference, Sundus, if you want to fracture before?
For me, I don't like to fracture before. I would like after. And again, this is a self-expandable valve. It's going to keep expanding, to some limit, of course. So that's why first of all, I would go for a self-expandable valve. Second of all, I will feel more comfortable considering that the coronary, the sinuses are good. And then I will not put a bigger valve, because this is already, we know the inner diameter. What we're going to gain, 2 millimeter extra after the fracture or 3, it's not going to be pushing a full size from 26 to 29 or from 29 to 34. So it's not going to be a major jump. And at the end of the day, we're not only treating the numbers, we're treating the patient. So we have to take in consideration how much is the patient functioning and moving, what is the weight of the patient, the height, and Abdullah has demonstrated that we can go a bit going with our hemodynamics. So after the fracture, you can then just go and see your hemodynamic to see if you need to go a further extra step or not.
Faisal, yes, you like to fracture before or after? Yeah. But quick answer, billah, Faisal.
I think it's always after, but the point that I would like to make is absolutely there are reports to indicate that you can upsize if you fracture before. And if you are in that range, probably you might fracture before in order to allow this patient to get a bigger valve. But the literature, which is driven by a balloon expandable literature, indicate that fracture post is always better.
Okay. Dr. Timothy, if there is something we need to fix in the coronary, earlier or after the implanting the valve?
Well, I don't have anything really to add already to the excellent presentation, except for one comment. This is becoming an increasing common problem as people get older. So I think the essential thing is what you do the first time. And that's a really important point, I think, is to make sure that you put in the largest size you can safely put in the first time. And that's true whether I think you're doing it surgically or with TAVR. But I think this is going to become, a really increasingly common problem as we have more valves and people are getting older and older.
So now we have like other form or other platform of supraannular valves. Like we have limited experience with the other, but I think I don't know what's your thought about using have you ever been used like other self-expandable valve in such scenario, or it is the default evolute? Yeah. Do you get it?
Well, so I'm not, I'm not a structural person myself, yeah. And I was at both two places, yeah. At Cedars-Sinai and then now there, where very good structural people who did it opposite way. Yeah. So I don't know that there's a perfect answer to that.
Yes. Okay. So
one question, Dr. Jamjoom. So starting the approach of this case and the decision to go for a redo TAVR, what do you think, Dr. Jamjoom? Were there any surgical input there? Redo
is going to be for the surgeon in the nearest future something that you will commonly see. So
Assalamu alaikum. Just a couple of quick comments. For sure, the trends of putting a tissue valve is growing. To be honest, rarely nowadays we put a mechanical valve knowing that you guys are going to be capable in mitral, aortic to do a valve-in-valve. And I think this is an important point that Dr. Timothy mentioned is just make sure as a surgeon that you put the largest size valve capable for the, available for the body surface area. Even if that needs a root enlargement, then it becomes easier for the next time for the interventional cardiologist to do so. The third thing I always get worried about is endocarditis. We did have a bit of an increase of endocarditis at the beginning of transcatheter valves when it started at King Faisal. And when we've gone to basic, we have identified it's really, taking care of dental clearance issue on the patient going for TAVI or melody valve in the pulmonary or valve-in-valve. The other thing is the stringent criteria for sterility in the OR is different than the cath lab. And we have applied the same stringent criteria in the cath lab, and that just reduced the endocarditis rate significantly. The third thing is just make sure it's a teamwork. A surgeon has to be aware what's going, and God forbid an urgent procedure is needed, then where is he going to cannulate? Is it the neck? Is it the groin? So this has to be discussed before and planned.
Excellent. Thank you so much, Dr. Jimjum.
I have a question for you, and then Dr. Jimjum.
1 minute, Ashan, we have to
Go ahead.
proceed. Yeah, let's proceed in the case.
Yeah. So as you can see, sorry for the quality because this is about cath lab, sheet, print sheet. So there is around 25 gradient after basically we did put the valve, and we did post dilatation with basically semi-compliant regular crystal balloon. So at this stage, it's basically we're kind of expecting that. So what we did basically we took a crystal, Atlas Gold balloon and compliant line, non-compliant size balloon 20. We did post dilatation for this patient. Then basically the gradient came in less than around 3 millimeter mercury, which is basically a great result considering the patient. So thanks for your attention.